So today we're gonna have something that I frankly have been waiting for, because there's a lot of different things coming down the pipe at the moment with the telehealth policies and some of the other updates, the DEA updates. So Jonathan Newfield, who is a part of the Great Plains Telehealth Resource and Assistance Center, is going to be talking with us today. And so we'll kind of let him get going in a second. I'll quickly go through all of our fun things, even though what I should do really is have somebody different each week read these, because I think they would probably read them from heart. Next slide, having heard them so many times. So the announcements, again, we have some amazing talks coming up. Remember that last week, Isaac Marsalek said he was going to be coming back for the centralization talk. His talk last week on back pain and opioids was amazing. So lots of good ones come. We got Amy Krentzman next week, but lots of different ones. And again, coming down the road, I'm going to be doing my talk, which everybody expected me to do, on compassion fatigue, which I think most people feel like that's probably something I have tons of. I'm a compassion fatigue kind of guy. So that one will probably be sometime in June. We also have one that's going to be on acute prescribing in June, which is going to be great. So lots of fun people coming up. Next slide. Remember, free CME, if there's somebody in your room that you want to get CME, for instance, Mona Lisa will be getting some CME. I put her name in. So if you have people in the room, make sure that you let us know so that they get the CME. And again, I think our speakers always love it when we turn videos, just gives them something to talk to. So again, if there's anything that you need as far as information or questions, we've had some pretty tough questions lately. So feel free to reach out to us. Erin is actually on a cruise, so don't try and call Erin. Next slide. Yeah, she's tanning. So, and again, the Center for Opioid Resource Education, there's lots of different information and protocols on there. The manual will be on there very shortly. Yes, I see that every week, and I do mean it. It's going to be on there shortly. I'm just not going to define shortly. Next slide. So the Addiction Connection last week was actually on our compassion fatigue. So please feel free to read that one. It's pretty popular, lots of downloads. Next slide. So today, again, and I don't know if, Jonathan, you wanted to share your own slides. I'm assuming so. So we're going to let him introduce himself and a little bit about what he does. Again, this is a talk I've been kind of looking forward to, because some of these things are going to impact us in the near future, and you need to know what's going on. So thanks again, Jonathan, for coming on. We're just thrilled to have you as usual. I hope everybody enjoys this.
Hey, thanks, Kurt. I am going to assume you can all see my slides, and stop me if you can't see me or hear me or whatever. I was just telling Kurt before everybody joined, I'm going to talk primarily about the new proposed rules that DEA just put out. I can talk a lot about telehealth in general and changes that are happening in general to telehealth policy, but I'm going to focus on the DEA stuff. And feel free then to raise any questions you have about any telehealth related stuff. I'm not going to guarantee that I can answer them. I am not a physician. I'm not an addiction specialist. I'm a clinical psychologist, but I've been doing telehealth for over 15 years and following policies, and hopefully I can speak intelligently about a fair bit of this stuff. So don't hesitate to bring up questions, and we'll address them as best we can. And hopefully we can provide some value here to folks in this experience. So I'm out of the University of Minnesota Institute for Health Informatics, although I live in northern Indiana, and actually right now I'm coming to you from beautiful Santa Clara, California. It's a long story. I'll tell you another time. But we are my center, the Great Plains Telehealth Resource and Assistance Center, is one of 14 telehealth resource centers funded by HRSA to provide telehealth information. 12 of us are regional across the country. And then we have a center that focuses on policy and a center that focuses on technology only. So our job is to stay up to date with telehealth, all things telehealth, everything from mental health to medical to remote monitoring to whatever else is in the domain of virtual care and connected care and telehealth. So we try and keep as aware of that whole world as possible. I'm going to say just a little bit about the structure of regulation and reimbursement, a little about the Ryan-Haight Act, which hopefully won't bore you, and then the new DEA stuff that has just come out. And I have a few learning objectives. These are fairly generic in that you'll understand some key regulatory issues, recognize the types of changes and the timeframes in which they occur, and then know the current status of the regulatory flexibilities around telehealth and how they relate to your practice. All right, so just a couple of general comments about regulatory context. We talk a lot, although you folks probably are a little more aware of this than a lot of people I talk to. We talk about what can I do in telehealth, and we got to separate the question of what you can do versus what you can get paid for. What you can do, and most of the time people are worried about what you can get paid for. Those of us in healthcare know there's a whole lot of stuff that you can legally do that is very, very helpful, but you can't get paid for it. And so we need to know that there are both of these questions floating around, and we need to disambiguate them as much as possible, because there are times when we do things that need to be done and are helpful, but then we don't bill for them. And there are other times when we're building a business plan or we're sustaining our clinic, and we realize that you can't sustain a clinic if you can't charge for what you're doing. Okay, you know all that. What's legal is regulated at a couple of different levels, and the one is federal laws, which are then implemented as federal regulations by federal regulatory agencies. And then you've got a whole different level at the state of laws and regulatory agencies, and in addition, licensing boards. And of all of those, the primary one that impacts telehealth is your licensing board. That's where most of the rules that say what you can and can't do exist. Now, in our current context, we're going to spend a little more time at the federal level than I usually do, because the one thing that does happen at the federal level is regulation of controlled substances. And in specific, one of the few federal laws that actually mentions telehealth by name, telemedicine actually by name, and that's the Ryan-Haight Act. And I'll go into that a little bit more. And the agencies that promulgate the regulations that implement the law. There's a couple of layers there. You guys are probably more familiar than most with this, but the law says one thing, and then the agency has to say, okay, what that means in terms of CPT codes or county lines or, billing and charging or whatever, those specific regulations that implement the law are done and enforced by regulatory agency, federal agencies. All right. As far as what's reimbursed, you all have been around this block, and it's payer by payer. We have a federal policy with regard to Medicare because it is a federal payer, but then states all have their own rules about what gets reimbursed in their Medicaid programs. Sometimes Medicaid programs use MCOs that have their own varieties of regulation or policies, and then commercial plans can go all the way down to the contract by contract, what's reimbursed and what isn't in telehealth. And that's part of the reason why there's a grant program that sustains me, because there are so many layers of policies, and they're not all uniform. One of the things, just as an aside, good things maybe about what happened during the PHE is that all of a sudden there was one set of rules, and it was basically anything goes. Anything you can do, any system you can use to connect with patients and provide care is going to be okay for now. That was kind of the gist in the vernacular of what all the flexibilities were trying to do during the PHE. It's like people can't see their doctor can't see their patients. Okay, how do we do that? How do we make this happen? And the policies were flexed to the point where you could do a lot of things. I would say just about anything, but in a sense, any reasonable thing to connect with your patients and provide care. And so we got a sense of what was possible during the PHE. And so now those rules are fading, are ending, and we're going back to the kind of patchwork that we had beforehand. The other thing I want to say before going into the Ryan-Haight Act is that, well, I'll save that. I'll save that for later. Okay, Ryan-Haight Act and a little bit of the ghost of regulators past. This I have to say, this particular law has bugged me for a long time because it came out, and it's for good reason. I mean, good intentions here, but it ended up putting into our legal parlance a term that was absolutely unhelpful, and that is providing medicine via the internet. Because at the time, in 2008, what regulators understood the internet to be and what it is now in 2023 are very, very different. The intention is still good, but what they were talking about was going onto a website and typing in information, and based on that, getting a prescription and a delivery at your doorstep of a controlled substance. And I think we can all agree that's probably a bad situation. That is not something we want to have happen. But once you said we're going to control the use and distribution of controlled substances via the internet, it kind of leaves open, what is the internet? What does that mean? Because at the time, a website is very different than what we're doing right now, live video, and the things that we've done all through the pandemic. All of those use the internet, but it's very different than what regulators had in mind way back in the day. So we're dealing with that legacy for better or for worse. And because I'm federally funded, I can't say it's better or worse. I'm just going to say what it is, and it is what it is. So Ryan-Haight, you probably all know this story, and I have my own skepticisms now. It's 2023 after all, about how much of this is reality and how much of it is marketing. But basically, a kid got a hold of Vicodin and overdosed on it from a doctor he'd never seen when he typed in on a web form on the internet. And the Act prohibits dispensing controlled substances, quote, via the internet without a valid prescription. Then it goes on, instead of just saying what that means, it goes on to then define what a valid prescription is. And they said to be valid, it means that you have to have provided an in-person exam of the patient, evaluation of the patient. And so based on those fundamental pieces of regulation, we have this idea that you have to see a patient, physically examine a patient before you can provide a prescription. Now, there are a lot of ways around that. In the law itself, there are 7 exceptions. If the patient's being treated at the time in a hospital or clinic, they're in the physical presence of a DEA-registered practitioner, they're at an IHS facility, they're being treated during a public health emergency. We just all have a lot of experience with that now. Treated by a practitioner who has obtained a, quote, special registration. We'll come back to that a little later. Treated by a VA practitioner during a medical emergency. I'm not sure why. I mean, that's the classic 2 conditions that you don't need both of them because you've got one of them in the other exception already. And then finally, other circumstances specified by regulation. So there are these 7 exceptions. Just to cut to the chase a little bit and steal my own thunder, number 5 was the one that we thought DEA would specify, and they have been under orders from Congress to specify since 2008, since this law came out. Congress reiterated that in 2022. Hey, DEA, you still haven't given us those special registrations we asked for. Still nothing. And then finally, what we do have now from the DEA says, oh, by the way, we're not doing that. So we'll get to that a little bit later. And I'll have some more to say about that. So during the PHE, public health emergency, of course, as you saw, one of those exceptions was that the tenets of the Ryan-Haight Act were suspended temporarily during the public health emergency. So here's where I'm going to say what I was going to say earlier about the regulations and the PHE. Three major things happened. Three major flexibilities came into place during the PHE. One was that Medicare agreed to pay for a number of services delivered via live video and or audio that wouldn't normally be paid for. And there's a whole conversation we can have about this, but basically I talk about this as Medicare's core services and reimbursement during the public health emergency. That's one. The second thing was that HIPAA regulations were suspended, and we know a little bit about that and what that means. And the third was that DEA regulations were suspended. At the end of the PHE, which happens May 11th, those second two, the HIPAA flexibilities and the DEA flexibilities, go away. All right, because those you have to have a PHE for those to be in effect. Now, you also have to have a PHE for Medicare to be able to alter its regulations around reimbursement of telehealth. But Congress was kind enough to give HHS special permission to extend those coverages beyond the end of the PHE, first for 151 days and then until the end of 2024. So Medicare's reimbursement and flexibilities around reimbursement with audio only and with non-rural sites and with FQHCs and RHCs and with all those other providers and all the other things that they did, that Medicare did to say, we're going to pay for telehealth in a much more flexible way. Congress said, okay, we'll give you permission to do that beyond the end of the PHE. For the other two, for the HIPAA and the DEA flexibilities, the PHE gave them enough. The PHE gave them the authority to do that and gave Medicare the authority. You just can't extend it beyond the end of the PHE without Congress actually acting. So that's the distinction. And that's why we, in the context of opioid treatment with telehealth, we have May 12th as a signal date for us, as an important date, whereas the rest of the telehealth community can kind of kick that can down the road to the end of 2024. So according to the DEA, the flexibilities during the PHE, which we're now currently in, include flexibility that allows us to issue prescriptions without having seen the patient in person, and as long as we're using audio real-time live video. There is also flexibility right now that we can do that via audio for some drugs, and that of course we have to be always acting in accordance with applicable federal and state law. As a psychologist, it always strikes me that when somebody says, okay, the law is that you have to follow the law, it says something's going on there. There's some kind of obsessive thing about rule following that maybe shouldn't be commented on at this point. Okay, so there are specific flexibilities that have to do with Suboxone, and those include that a practitioner can prescribe a controlled substance to a patient using telemedicine, even if the patient isn't at one of those facilities. That's the general flexibility. The specific one is that you can prescribe buprenorphine to both new and existing patients or existing patients to manage opioid use disorders based on a telephone evaluation. Now, you can also do it with live video. That's part of the general flexibility, but you can also do it with an audio-only telehealth encounter. And then added in, this isn't part of that, but I think you probably all remember that new patients treated with methadone still require an in-person medical eval. So that the general flexibility saying you can do evals and prescribe controlled substances using live video. And I'm not sure under whose authority, if it was DEA or congressional or what, but basically the one kind of blacked out exception there is new patients being treated with methadone. Continuing patients, existing patients, that's okay. But to put new patients on methadone, you still have to do an in-person exam. That's during the PHE. Basically, that part of it, the methadone part, is not flexing during the PHE. I got a couple links here you could follow up on. And in case those rules aren't clear to you, of course, I don't know how many of you have seen this, but the DEA provides a handy-dandy little workflow here. This is just half of it. This is the half that tells you what you need to do to evaluate the patient. I find this a bit dizzying, but basically it says what I just said in the last slide, that you can, yeah, I don't find this terribly helpful. It's mostly in here to.
Jonathan, I'm not sure if you're going to be touching on some of the nuances of doing these things as well across state lines. Is that something you're going to be chatting about?
We can certainly address that, because part of the flexibility, and this will come up as one of the things that's going away, but part of the flexibility is that you could do that across state lines without the DEA said you didn't have to be registered in that other state as well as your own state. That's part of the flexibility. That's going away. Come May 12th, it goes away. So, and what they're offering in place, well, we'll get to that. What they're offering in place is basically no change. But you have to, in fact, I would say that they've articulated a new policy that is more restrictive than how we were operating before, in that they have specifically said you have to have a registration both where the patient is and where you are, because medical licensure doesn't work that way. You only need a license where the patient is. That is, if they're across the border in Kentucky and you're in Illinois, or Indiana, you can be licensed at where you work. You don't have to be licensed where you live or where you're sitting at the time. But the DEA said, no. And with regard to controlled substances, you need both registrations. I don't know if that's where you're going with that, Kurt, but that's.
Yeah, I think that one of the issues, with benzos or with buprenorphine is snowbirds. And so, during the public health emergency, I had a lot of people head to Arizona and just stay down there. And it wasn't a problem. And they're still going now every winter. And so how do we navigate that?
Yeah, the DEA does okay, the editorial hat going on here, but the DEA does not have an adequate answer to that question. They really don't, other than Arizona and Florida and every other state people might go to, as well as being licensed there, although that's not DEA's purview. Licensure folks have been a little more flexible in that regard, but DEA doesn't have a good story for that. They don't,
because the reality is this is an enormous barrier. Because
exactly.
when these people go to Arizona, to find somebody to do buprenorphine for them and to get into a program is super difficult.
Agreed. Yeah, I'm not sure. Yeah, I thought that we learned a little bit more about all of this from the PHE, and I'm learning a fair bit about the DEA now, not in terms of actual policies, but just their personality as an organization that it just doesn't. I would think that we would have known better by now.
Yeah, and actually, one of the providers named Kathy Nevins, who's involved in some of these regulatory things at the state, she says, "Well, what do you use for an address in the other states? If you use your home state, the DEA says you already have one then, right? So there's no way to actually register because they already have you somewhere else. So it is a conundrum."
I'm sort of hoping that some of this gets sorted out as we hit the buzzsaw here and people start to complain. We're jumping way ahead here, but there is a comment period going on, and hopefully the DEA has gotten an earful. They are required to go through all of those comments, and there was no shortage of comments, at least on the internet, of public, blogs and whatnot, posts about the new rules, complaining about this and that, blind spot or catch-22 or whatever. So hopefully there'll be some changes.
I think we're all aware of how responsive the government can be.
Exactly. All right, so the proposed rules, they're commenting, they're posted here, and they took comments until the day before yesterday, whatever it was. Hopefully they got some good information there and are going to be responsive to that. So here's a summary of the rule change. Schedule 2, and I'm going to apologize ahead of time in case I mix any of this stuff up or blur things together. This is just not stuff that I work in every day. But Schedule 2, controlled substances, and Schedule 3 to 5, other than buprenorphine, can't be prescribed without an in-person evaluation. So going back to the bad old days, for buprenorphine and non-narcotic Schedule 3 to 5 drugs, you can prescribe a 30-day supply without an in-person exam. If it's for a legitimate medical purpose, I don't know why they have to throw that in. Commented about that before. Anything beyond a 30-day supply requires an in-person visit. And if the patient has already been, if they're being treated now, there's a grandfathering in sort of a clause, but it's basically 180 days. Get that exam done within half a year.
I have a question about that.
Yeah.
When you say you cannot prescribe like Ritalin and Adderall without an in-person evaluation, is that every single time they need a prescription, or they have to have one in-person evaluation ever?
One. This is, in fact, I should have said this at the Ryan Haight. The hurdle to get over in Ryan Haight is one physical exam. Once you've seen the person one time, and I don't know if this has been tested legally, like I saw them when they were 12 and now they're 35 and I'm still their doctor. I don't know. But one physical exam and then Ryan Haight goes away. There is no, you're good to go. You can prescribe, you are their doctor, you've done your exam, and you're subject to state laws and others, but as far as Ryan Haight is concerned, you're done. So that's at least a little bit comforting in that regard, or at least flexible in that regard. All right. There are a couple of things that they've added. Okay, so there's that restrictive policy, the 30-day policy, but they've added a couple of things here that are supposed to give us an out, and we'll go over these in detail and see what you think. Well, regardless of what you think, this is what the policy is going to be unless they change it. The idea here of a referral, they have specified this in a way that I think does provide some flexibility, and that is this. Somebody, a physician with a DEA registration or a practitioner with a DEA registration conducts a physical exam. And then that person makes a specific referral to another provider. And that second provider then does their own virtual exam and can prescribe then at that point. So in effect, you rely on the in-person medical exam provided by the person making the referral, by the provider making the referral. DA specifies a lot of documentation around this, and PIs of both practitioners, of course, names and dates, locations, when all this is done, they want this all documented. But then you can rely, you as the prescribing opioid treatment program provider can provide controlled substances to that patient based on that referral. You are still subject to, and this gets specified as well, subject, you got to make sure you check the database in the state where the patient is and make sure all of that happens. And if you have any trouble, you've got some deadlines here by which time you have to have checked and documented and rechecked and document all those times you checked. There's a lot of overhead here. But then if you've gotten all that done, then you can provide those controlled substances prescriptions. It's as if you've gone over that hurdle then. Now a physical exam has been done, you're over the hurdle, now you can prescribe. Okay? So
Jonathan, it would seem a little confusing to me when they talk about, they're seen once and you say, well, then you wouldn't have to see them for another 20 years. There's nothing built into this that, for instance, in our clinic, if we see them, I think we want to see them at least once or twice a year. right? I mean, that's kind of the standard that we live by. Is that not built into any of this?
No, it is not, because specifically for a couple of reasons. And again, I'm bordering on editorial here, but basically the DEA is not going to tell you how to practice medicine. Your state board is going to make sure that you practice medicine that way, or your peers in the addiction community are going to make sure that you practice that way. And that those are all good things. But I would also probably suggest you don't want the DEA telling you how to practice medicine. The DEA wants to put a floor, a very low floor, and say at least this, and then we'll turn you over to your peers in the physician community or your licensing board or whatever. So I think that's the best way to look at this particular thing, and because we're talking about a federal policy enforced by the DEA under penalty of criminal law. Okay, so they're saying this is the floor. Beyond that, your license, your state board is going to make sure that you don't mess with that or don't do that badly. That makes sense to you, Kurt? Yeah, I mean,
I'm getting a really good headache, but yeah, it kind of makes sense to me.
Okay. And I think and this is why I started where I did with federal and state and licensing board and all of that, because the federal laws don't always make a whole lot of sense. But again, the federal laws are not where we get most of our marching orders as providers. Most of that, the bounds around what we can do is mostly from our state boards. And that's, I think, probably a good thing in most situations. Although the good part, that's not my business to say what's good or bad about policy. All right, so another thing is record keeping. I mentioned this a little bit, and I'm going to say a little bit more about this with regard to the telemedicine prescription, because this is a new term of art, and I'll get into that in a bit. But they want documented the date of any prescription, full name and address of the patient. Okay, yeah, right. We know the challenges there, at least as far as addresses and changes of address. Drug name, strength, dosage, of course you do that. The address at which the practitioner and the city and state at which the patient are located during the telemedicine encounter. If you're at home, working out of your home office, I'm not sure what they mean. Do they mean you're working out of your clinic because you're calling in virtually, working out of the clinic? Do they want your home address, apartment 2B? We'll see. And I have to say too, I'm sorry to have to say this, but you could call a helpline and ask for somebody to do a presentation and tell you and answer this question, and you might hear different things from different people, because it will take a while for this to become sort of canonized as what this actually means as far as your name and address when you're providing that prescription. You're on your way into the hospital and they call and say, hey, can you renew this? You're going to see the patient as soon as you get, who knows? I mean, it's just, there's a lot of crazy stuff that could happen there. And we'll see what that exactly means. If the prescription was issued through a qualifying telemedicine referral, I'm going to talk about the telemedicine referral and the telemedicine prescription a bit in just a second. But in addition, then you need name and NPI of the referring practitioner and a copy of the referral document and other communications from the referring practitioner. So if you're going to rely on somebody else's exam, you need to document that and have a copy of their referral to you, whatever that looks like. And that includes, at a minimum, at least, diagnosis, evaluation, treatment plan. And every time you try to access the PDMP system. All right. So a little bit of additional overhead here if you're going to rely on someone else's exam and do this process. Now, and this is a little bit of an aside, but I'm going to make this point now, and then I'm going to go on to talk about something that's really important. So these proposed rules do not specify or do not constitute in DEA's mind exception number 5, a special registration. They are specifically saying this is under exception number 7, other rules that DEA and HHS can agree on together, and under new regulations. And so these are the new regulations, and the exception says that basically you're doing telemedicine under some other circumstances that DEA and Secretary of HHS have jointly agreed to. So they're claiming that they're working with this exception. DEA, of course, as a regulatory agency, can only act to the extent that Congress gives it the ability to act. All right, there's this really big dynamic that all federal agencies operate under. They cannot make laws. They can only implement laws. And they implement regulations, which are not laws, in alignment with the laws. And so DEA is claiming as its legal authority, Exception 7, to do this. And these are other rules we worked out with HHS, and so that's the exception that we're working within. I'll probably swing back around to this, but the reason why they're specifically not doing Exception 5 I mentioned before is basically they're saying, we're not going to do Exception 5. We're not going to give you an Exception 5. I'll talk about that later if we have time. Here's what I want to talk about, these new terms of art. You know what a term of art is, right? Legally, right? It's a word that has a specific meaning in a specific context. Some of the comments about this rule specifically refer to this thing that DEA did because it is a potentially very confusing thing. A qualified telemedicine referral. This is a term of art, and it is one of these referrals that we've just been talking about. Somebody with a DEA registration does an exam and then makes a referral to somebody else, and they document it to the nines, and they do all this stuff. That is a qualified telemedicine referral under these rules. Okay, that's not so bad, although when somebody's talking about a telemedicine referral, do we know that they're talking about one of these, or are they going to use the term in some colloquial sense? It's confusing in that way. But at least we can understand, okay, is this a qualified referral or not? And do we want to document it to make sure that we're in compliance with the law? The worst term, can't judge this, but the other term is a telemedicine prescription. That is now a term of art. Telemedicine prescription. It means a prescription that you, the recipient of the referral, make specifically under the framework of this exception that we're talking about, under these new rules. I got a referral from another provider who did a medical exam. I'm supposed to provide OUD treatment. I'm providing a prescription for this person that I have not personally examined. And that term of art they're saying is that telemedicine prescription falls under these rules. That one's going to get abused and misused and misunderstood. We can practically guarantee it. But those are two new terms of art that exist now with this new terminology that we need to be aware of, at least that they exist, that they're out there, that there's potential for some confusion. And if we're going to rely on these new rules, we're going to have to be sure that we do these things and use this nomenclature as we do them. All right. One more comment. I'm getting to the end here. Use of audio only, the new rules. Let me just look at my time. The new rules incorporate the changes that Medicare made that basically say for behavioral health care, audio only is as good as in person. Medicare made this change separately. Medicare kind of stretched its legal authority and said, Congress says telehealth can only be done by these providers in these places, in these ways. And Medicare says, we can't go beyond that because we're not Congress. We want to be a good agency. But Medicare did say, dang, behavioral health is so hard to do under these rules. We're going to stretch it and say, you know what? Telebehavioral health, and including audio only, that's the same as in person in the behavioral health world. That's just the same as in person. And so they redefined telebehavioral health care as functionally equivalent to in-person care in the behavioral health space, not the medical space, but in the behavioral health space. And you guys are all crossing over in the medical and behavioral, right? You're in both. But Medicare said, we're going to treat those the same. And so the DEA recognized that and said, okay, for these behavioral health prescriptions, audio only is going to count as well as live video. Again, this is the DEA, so they have to have a couple extra parts to it. And they said, if you're going to do audio only, that is telephone care, you have to be technically capable of meeting the audio video interactive standard. And you can only use audio only if the patient is unable or refuses, doesn't want to, doesn't have access to live video. So if the patient says, hey, I can't do that, don't want to do it, not interested, whatever, then you can use audio.
So you're saying that has to be documented?
Yes.
Okay. Because that's happened many times where we're trying to get theirs going, won't go. We just, and okay.
Bounce to audio, right. If DEA is going to be involved in some way, they want to know that you tried that and why and for what reason you went to audio. Yeah.
To back up just a little, and Dr. Bell had a question. I don't know if she wants to answer it or ask it or wants me to, but Heather, did you want to ask it or no? I'm saying no. So here's the, she asked whether or not.
Sorry, Kurt, I was just trying to unmute. So when you say that the referring provider, can do the physical exam for the, recipient of the referral, does that referring provider need to be able to be X-waivered in order to put in that referral and count as the exam for the recipient of the referral?
Yes. They have to also be, well, okay, X-waiver, that's different.
Because that's gone.
Yeah, that's gone. Right. Thank you. No, they don't. They have to be DEA registered, but they don't have to specifically be X-waivered. No.
But that would be new. That's just changed. Right. I mean, because a month ago, they would have had to probably be waivered.
So these rules are not in effect yet. And because what we're talking about, the X-waiver system is, this is very brand new as well. My understanding is that they're not resurrecting that system in order for this to happen. They're just saying the person have to be providing care that they are legally allowed to provide. In other words, they're a provider with a DEA registration.
But in reality, isn't this part of the whole big problem? Is you keep saying it appears to be, or this is likely. We're all out here, and I don't think I'm the only one in the audience that's been reading this stuff going, well, is it or isn't it? Or is this right or is this wrong? And you've probably the clearest person I've ever heard talk on this by a long shot, but still it's gray.
Well, yes, exactly. And I would, I think that the folks who are making these rules are not, obviously, you and Heather. They're not anyone on this call. They're not people who do this every day. They're not people who are trying to figure this out. And part of the frustration we have, in the telehealth community, we have this all the time. We'll get MACs on the line, Medicare contractors, the ones who implement the Medicare rules in the states, and one MAC will say, here's how you interpret that rule, and another MAC will say it's something else. Because all Medicare will say is, here's the rule, you read it. Because nobody wants to go out on a limb and say, here's what it means. And so you get this situation where stuff that's gray, stuff that's vague, nobody is on the hook to clarify it one way or the other. And so you end up without it being clarified. And I think that happens a lot.
Beth, did you have a question? You looks like you unmuted.
Oh, no, sorry.
Okay.
Let me see what else I have. Oh, okay. I have two last things to say, and then we can open it up to questions and discussion if we have any time left. As you know, federal laws preempt state law to the extent that they're more restrictive than state law, and of course you have to comply with both. Of course, there's plenty of possibilities where these are going to conflict, but not my problem. You have to comply with both kind of thing. And the other thing, the last thing that I wanted to say, and this is where I get firmly into the realm of editorial. Also, the information is that when DEA says we are not providing a special registration for telemedicine. In other words, we're not providing Exception 5, which has been on the books since 2008, and Congress has said, please do this. And then in 2022, they said it again. Hey, please do this. You're 5 years late, or 15 years late. DEA has basically said, this is the end of the line. We are not giving a special registration for telemedicine. No further registrations are planned. Now, that's what DEA says. The implication being that, and this is the one that flummoxes me. The implication being DEA is basically saying, Congress, we're not going to do that, which I'm not sure. I mean, that seems a little bit unprecedented. I'm sure there are precedents for it, but it seems a little odd to me that DEA can just say, no, that was a good idea, Congress, but we're not going to do that. Or we don't like that idea, we're not going to do that. So regardless, we don't need to just get into a complaining session, and I sure don't want to go there. But it is an interesting thing, just FYI, that the DEA is saying this. We are not going to do the thing that we've been told to do.
Wow. Wow.
All right, we can have some Q&A, and I just have to, there's a pause 10 seconds for a note from our sponsor. We are doing a conference in the spring. Please come if you're interested and if you can. And that said, we will go to Q&A.
If people want to unmute, I think that's fine as well. You don't have to chat it in. We can make this real informal.
I will stop my share, but if somebody wants to refer to a slide, oops, let's not do that. Let's do it this other way. Stop share. If somebody wants to refer to a slide, feel free. I can pop them back up if we need to.
Hey, I'll share a comment. Hey, everybody. It was great talk. Thank you for that. I had the opportunity a couple of weeks ago to go to DEA headquarters and talk to them about these changes. You nailed it. I mean, I think you covered everything perfectly. There's a couple interesting thoughts. I could share some of my observations from that conversation I had with them. DEA headquarters is the most secure building I've ever been in my life. It's insane. But whatever, that's aside. The one thing they said over and over is, look, it is not going to be our priority to enforce buprenorphine prescribing regulations. So whatever else happens, we really want buprenorphine providers to know that if they're just reasonably trying to do the right thing, we have other priorities, which I thought was interesting. And I said, can you put that in writing, please, DEA agents? And they said that they may do that. They may actually, they are so worried about the opioid epidemic that they want to encourage buprenorphine prescribing when appropriate, and they will not be enforcing, like going out there doing audits and aggressively trying to bust people for buprenorphine prescribing, which I just thought that was a really interesting statement on their end. I don't know how much we can trust it, but that was one thing that they said.
Wow. So Charlie, was it your feeling from them that if we kept doing a fair amount of it telemed, and occasionally we're seeing them in person, that to them, that's not even something they'd even look at?
They were exactly what the speaker said. They are trying to establish the floor. So if a person, they are not expecting someone to be seen with any number of frequency. They're not setting the standard of care. They're setting the floor. And what they're trying to do is prevent these. Someone in South Carolina is sending buprenorphine all over the nation based on phone visits with, it's all getting diverted and it's just a mess. They're trying to prevent that kind of diversion. But they're not setting the standard of care, if that's your question.
Because I'm interested in you, Charlie, whether you get snowbirds and you do a video visit with them and send their bupe. Because I do.
I did. Well, I don't send bupe across state lines because separately my institution doesn't want out-of-state telemedicine visits. And that's not about the DEA. So I just can't do it because I think of credentialing or something in our credentialing office. We actually didn't. We spent 2 hours with the DEA, our group, and we didn't talk about across state lines in this issue. So I don't know how to answer that question.
Well, it's interesting because there's these ways around. I can prescribe buprenorphine to my local pharmacy, but I can't tell my patient where to pick it up. Right? So then you can go to a Walgreens somewhere else and they can get that prescription. And I sent it local. And of course, I didn't figure that out. They figured that out before I did. They'd say, oh, send it to Walgreens. I'm like, okay.
When this all shakes out, I would contact the local DEA agent. I've contacted the local DEA office like frequently, like once every couple of years, and they are always respond pretty quickly. And they're pretty helpful. They're like no nonsense gumshoe law and order types. They're not medical types, but they respond and they're helpful. So I would just ask them.
Huh. Interesting. Other questions for Jonathan? Man, I think you may have covered it all.
Well, here's my question. If you've got different regions interpreting things differently, how are we as providers supposed to figure this out?
Yeah. I think it's just a way of expressing the challenge that we're all in. And I'm hoping that there will be some sort of sifting and sorting and some sort. This has been an issue in telemedicine, an issue of mine for a long time in telemedicine. That there should be some. I would love to see some responsibility to provide a canonical interpretation, a canonical FAQ, if you will, of what these rules mean. And unfortunately, in a number of situations, not just this one, although this one has criminal implications, there should be a way you can go and look this up. And as decisions are made, they become part of a record that other people can reference, other than post adjudication, right? After you've been sent to jail, then everyone else can reference that record. That's no good. But there really isn't a place like that. In fact, your local DEA agent, I hope that they are the kind of folks that Charlie is describing. If they tell you something different than what you've heard from somebody else, I don't know where they go and who they call and how they get their marching orders and talking points and interpretations for the myriad variations on these questions that they are going to address across the country. Because we've just recognized that for years now in the telemedicine world, there are places where the rule is vague. There is no two ways about it. As much as some lawyer can stand up and say, no, this is what it means, the next lawyer can stand up and say, no, reasonable people can disagree. And there is no, like I keep saying, canonical interpretation. I wish there was some place with the responsibility to provide that.
I mean, it's not that the federal government doesn't do it, because I do FAA exams and they're quite clear on how things should be interpreted, and DOT exams, a little more wiggle room, but it's not that they don't do it.
I think part of it too is a how would you call it, a built-up experience, institutional experience. I mean, so these rules come out, and for the first year, however long, it's going to be, well, what about this? What about that? What about this? And eventually, hopefully, we'll see some refinements come in. Now, here's what we mean by that, or here's a subsequent law, or we've now updated those policies. I mean, the FAA exams, I don't know about them, but they've been done for a long time, and so they can be very clear about what counts as an elevated blood pressure or whatever they're interested in. Whereas I think we're going to have a sort of a, like it or not, we're going to have a period of, where a few of the uncertainties and edge cases are not quite clearly specified for a little bit here. Hopefully it's just edge cases. I hope it's not the core of your business and your standard of care.
Yeah.
Well, the other thing with the snowbirds is, who's going to provide them better care? They walk in and see somebody down there who's never met them, or a televisit with their primary.
I'm continually amazed at how poorly CMS as a whole understands the phenomenon of snowbirds. Telehealth has fought this for a long time, struggled within it for a long time, because not just OUD care, but all kinds of medical care has been provided to snowbirds for years via telemedicine or other means. And it's just the situation just never comes up other than, refer to the laws, refer to the state laws where the patient is at the time. Just so it's clear, the legal standard of what healthcare is done and whether you abided by it or whatever is tied to the patient. So if the patient is in Arizona, the laws of Arizona apply, whether that's your licensing laws, your CE laws, your whatever laws, it applies where the patient is at the time that care is provided. That's the technical term. Now, there's a lot of flexing around that, and a lot of organizations will say, yeah, for a little bit here and there, we're not going to worry about it. And that's kind of what happens across the community. But we're talking here about something that's a snowbird is more than they're there on vacation. They're there for an extended period of time. They set up, the IRS deals with this. You have to file a part-year resident tax form, right? There are ways that we can do this, but CMS is behind in recognizing that.
Well, to be clear, Jonathan, I'm not old enough to know that if I'm not a snowbird, not even close. Not even close.
Okay.
Yeah, that whole snowbird thing though is just I think for us it's really a big thing because I probably have half a dozen Suboxone patients, and Dave, I'm assuming you have some, and it's like there are some ways around it, and I don't know if I'm being, I hope there's nobody from the DEA listening in, but it's like, Walgreens has been the saving grace because they can pick it up anywhere.
Yeah.
Well, and actually, maybe not so much now, but Florida was the center of the pill mills like 15 years ago. So
Yeah.
do you really want your chronic pain patient getting fills down there?
Yeah. No. Any other questions before we let Jonathan go? This was enlightening.
I would add that there was significant input from the stakeholders, which was like AMA, American Family, the National Family Medicine Organization, the pharmacy organization, et cetera, et cetera. There was significant feedback. I wouldn't be surprised if some of this gets changed. There was a lot of push to eliminate the 30-day requirement for a physical exam. I wouldn't be shocked if they dropped that. They said that they truly want to make sure that buprenorphine gets out there to the right patients. And there was a lot of feedback that this could create barriers for some. So I wouldn't be shocked if some of this stuff changes yet again.
Well, I sure hope so.
And if you really want a bombshell, there was a lot of talk about an X waiver for methadone. So that the way we used to have an X waiver for buprenorphine and prescribe buprenorphine out of an office, there was a push to, then there's consideration of doing that for methadone. Now that's a bombshell.
That is and here's one of the interesting things about that, Charlie. If you think about it, it's like, would a guy like me out in Timbuktu, well, St. Cloud isn't Timbuktu anymore, but would I want to be able to give methadone in certain situations? And the answer would be, hey, to get people off fentanyl and then slowly transfer them to bup, it would be amazing because they'd come out of it so much quicker and safer.
That was specifically talked about.
Yeah. But
could you still prescribe methadone for pain?
Yeah, I mean, that's an ongoing. Yeah, always. Pain is anything goes for pain, as you know. I mean, not anything goes, but yeah, the pain thing would be unchanged. It would be methadone for OUD. Yeah. That would be a specific X waiver situation. So that's being considered.
Wow. Candy, did you have a question before we go?
Well, it wasn't a question. It wasn't related to telehealth. I just wondered if you had all seen that the FDA approved the first over-the-counter nasal Narcan today.
Did not.
Yeah.
It's cool though.
Yeah.
More the merrier.
It's priced at $40 to $50 per package. A little pricey.
Yeah, of course that's going to be the barrier, isn't it?
Yeah. Huh. Cool. Well, Jonathan, you blew my brain up. I got a lot to think about now. Even the Mona Lisa here seems and looks confused by some of these issues. But hopefully, as the next year goes on, some of these things will be more clearly defined. I think we're all waiting for that. I think even at Stratus, with some of the people that are on this call, we've had these conversations. So what does it mean? The waiver went away. What does it mean? The rules that keep coming out are so interpretable so many ways. So we'll look for clarification. And hey, I tell you what, when you get all the clarification, you can say, this is the way it is. Make sure you call us, because man, we'd have you back in a heartbeat.
We will, yeah. As soon as we got that all nailed down, we will come back.
Yeah, I'd love that. That was a fabulous talk. Really enjoyed it.
Here's the question you should go out on is, how big an entity do you have to be able to tell Congress, no, we're not going to do that and have no consequences?
Yeah, I'll check with Centricare. I'm not sure they're big enough, but maybe Dave, maybe you guys.
Well, I would say one other thing too. It's kind of response to, I don't know, maybe this doesn't need to be said, but your policies are your friend in doing any of this stuff. Having policies and following them that's what you get judged on. So all your flexibility comes back to the policy when the rules themselves are a little bit ambiguous. So.
Yeah, perfect. All right. Well, thanks again, everybody, for coming, and thanks, John, for popping in. It was a talk that we're going to be thinking about for a while. So everybody have a good week, and we'll see you back next week.